So this is one of the most exciting times for patients with hepatitis C because new treatments are available. In fact, we're already moving from what became standard of care from the late 1990s for 10, 15 years, which was pegylated interferon and ribavirin. And that's changed, so we've been able to add in some of the newly acting acting antiviral drugs. The first of those was the protease inhibitors, that is telaprevir and boceprevir. With those drugs, we saw an increase in the sustained virological response rate, SVR, that is equivalent to a cure, in fact, in hepatitis C. But it came at a cost, not just a financial cost, but also increased rates of adverse events, particularly in those patients with advanced liver disease, particularly decompensated cirrhosis. So we became quite wary of using those drugs, but fortunately another generation of direct-acting antivirals has become available. First of all, there's a new protease inhibitor called cimiprevir, which has much less side effects than telaprevir and boceprevir. It also has a slightly wider application in terms of viral genotype, so it can be used in genotypes 1 and 4, although it doesn't seem to be so effective in genotype 3. But perhaps the most exciting drug that has become available to us to use in clinical practice recently is sofosbuvir. This is a polymerase inhibitor for the hepatitis C virus and is extremely potent and has a very clean side effect profile. So we're now able to use a combination of sofosbuvir plus pegylated interferon and ribavirin. And we're seeing a sustained virological response rates well over 90% in all non-cirrhotic patients of all genotypes, and very respectable SVR rates, over 80% in patients who have cirrhosis. Obviously, what we're looking forward to most in the treatment of hepatitis C patients is getting rid of the pegylated interferon. The side effect profile is well known to most people and is really quite difficult to manage. It requires a lot of resources as well as being unpleasant for patients, leading to discontinuation of medication in many cases. In addition, we'd really quite like to get rid of ribavirin because ribavirin causes anemia. It's also teratogenic, and many patients require additional management because of the side effect of anemia. So, in fact, with the licensing of sofosbuvir, for some patients, we already have an interferon-free regimen. For genotypes 2 in particular, a 12-week course of sofosbuvir and ribavirin will induce a sustained virological response in 90% or so of patients. It is possible to treat genotypes 1 and 3 with sofosbuvir and ribavirin, albeit that we don't get optimal sustained virological response rates, or we have to extend the treatment for 24 weeks. In fact, there are new drugs already going through the licensing process and reimbursement approval in the United Kingdom as well as elsewhere in Europe, which will be making all oral interferon-free regimens applicable to a wide variety of patients. So recently, cimiprevir and declatazvir, cimiprevir being a protease inhibitor, declatazvir being an NS5A inhibitor, these have been licensed, and combinations of sofosbuvir and cimiprevir or sofosbuvir and declatazvir should be available soon. One of the major advantages of having the all-oral interferon-free regimens is that they can be applied to patients who have more advanced disease. And this is quite an exciting prospect. There are several schemes and trials at the moment evaluating sofosbuvir and declatizvir and another NS5A inhibitor called ledipasvir in patients with really advanced liver disease, looking to see whether the elimination of viral replication will result in reconstitution of liver synthetic function and perhaps even be good enough to treat patients on transplant list and letting them being delisted in due course. Patients, of course, are delighted with the prospect of interferon-free regimens, and the other advantage of those regimens is that, in fact, they only need, in general, 12 weeks of therapy rather than the 24 or 48 weeks that interferon-based regimens have required in the past. Some of the patients who've previously been treated, so they are either partial responders, relapsed responders, or null responders to interferon therapy, have then been treated with these new interferon regimens. And sometimes they feel they must be on a placebo arm of a trial because the side effect profile is so good. And that is seen as a major advantage. At the moment, one of the major issues with the new regimens is they are having to go through the reimbursement approval process. In the UK, this is run by the National Institute for Clinical Excellence. And as they are relatively costly drugs, it may be that their widespread use will be somewhat limited by what is considered to be cost effective. So over the last few years, we've seen increasing numbers of drugs available for hepatitis C, which fall into the group of direct-acting antivirals. They come in several classes. The polymerase inhibitors, in fact, come of two types, nucleoside analogues, of which the only real example at the moment is sofosbuvir. The non-nukes, of which there are a couple of examples, the protease inhibitors, and the NS5A inhibitors. And in fact, the protease inhibitors are now coming through for probably their third generation, and the NS5A inhibitors for their second generation. There are multiple regimens that will be available in the foreseeable future. So we expect from the Gilead stable sofosbuvir and ledipasvir, albeit they have another NS5A inhibitor that will probably take the place of ledipasvir in due course. AbbVie have a 3-drug regimen, and that should be licensed in the first quarter of 2015. And Merck are coming through with a new regimen combining a protease inhibitor and an NS5A inhibitor. And BMS have declatizvir at the moment, and they also have a new protease inhibitor that will be coming through. So for patients, that means there will be a wide range of regimens available. And it's important, of course, that those regimens contain drugs of different classes. At this point in time, resistance to antiviral drugs has not really been considered as a major issue, but inevitably it will happen, and to have a wide range of regimens is going to be important in the small number of patients who fail to respond to the drugs that they were treated with first line. We expect in the future then to be a little bit of competition in the market for the drugs that are available, and that probably is going to be good in terms of driving the price or controlling the price of these regimens. One of the things that I'm looking forward to with a wide range of all-oral, interferon-free, potentially ribavirin-free medications is being able to use these medications not only in patients with advanced liver disease, of course they will be a priority, but we will also be able to use these drugs in patients who've been completely interferon intolerant for one reason or another. Short duration of antiviral therapy is incredibly applicable in patients who still have drug and alcohol problems or who are resident in prisons. This may seem a strange population to address, but if we are going to control the epidemic of hepatitis C, then we have to test and treat those patients, and they are not going to be able to use interferon regimens. So the new drugs offer a number of advantages, not just to the individual patient, but also to the whole population who are infected with hepatitis C.